Good evening, everybody, and welcome to Prostate Forum. It's our honor to once again welcome Dr. Gary Ulaner, who is a radiation oncologist with Hoag Hospital, Hoag Family Cancer Center here in Orange County, California. He is a welcomed and frequent guest of ours, and tonight he wants to bring us something that is getting more and more attention, and that is the use of lutetium-177, also known as Pluvicto, and the use of Pluvicto with a androgen receptor pathway inhibitor, because we will have a support group meeting here on top of this presentation, and this is a quick fireside chat. With no further ado, I'm going to give you Dr. Gary.
Thank you so much for the introduction, Neil. If it's okay with you, I'm going to share slides. That's me on a good day. And I do molecular imaging and therapy at the Hoag Family Cancer Institute, and I'm a professor of radiology at the University of Southern California, and I run a number of clinical trials as well as do all the standard of care radioligand therapy at the Hoag Family Cancer Institute. I do like to start by saying I have disclosures of who I work for, and I've shown this picture to the group before.
Yeah.
Just as a reminder, here are my two junior faculty that I like to teach molecular imaging and therapy to. They help me with these courses that I run, and they get really good really fast if you start them young. Just like anything, start people young and they'll get good fast. This is how I like to describe what I do with molecular imaging and therapy. We identify targets on cancer cells, and then we build binding agents that can hit those targets like a key fitting into a lock. Then we link those binding agents to a radioisotope. If the radioisotope gives off just a little bit of radiation, like something we call a positron, we've built a key that binds to a target and allows us to image the cancer. If I can use the same binding area, and instead of using a radioisotope that gives off a little radiation, I bind it to something that gives off a whole lot of radiation, now I have a key that can bind to your cancer cells and kill the cancer cells and be an effective therapy. This is the methodology behind what we call molecular imaging and therapy. First, we image to make sure you have a target, and then we can use a therapy to try and kill a cancer that has that target. I was speaking with a group from the Orange County Prostate Cancer Association. So, of course, we're talking today about a target called PSMA, or prostate-specific membrane antigen. This is a protein that exists in the cell membrane of prostate cancer cells, and we have agents that bind to PSMA. Someone was just asking me about PSMA-targeted imaging. The one that I like the best is called PYLARIFY, and this is an imaging agent that allows us to detect prostate cancer more sensitively than any other method that is currently available. This is what one of those scans looks like in a patient, where we can see things like the lacrimal glands in the eyes, the salivary glands in your mouth and neck, the liver, the spleen, the kidneys. And this is what you're supposed to see. And if you see anything else on the scan, that could be a cancer that's expressing PSMA. So this is the imaging that we do every day. This is the therapy that we also do every week, if not every day. This is that PSMA-targeted imaging agent, and this is a patient that has started before they get therapy, on therapy, and after multiple cycles of therapy. And you can see all what we talked about: lacrimal glands, salivary glands, all this stuff here are bone metastases that we can see before we start treatment. And after treatment with PSMA-targeted therapy agents, there's a miraculous decrease in the extent of the disease. This is not a cure, but it is a way of markedly reducing the extent of metastatic prostate cancer. And this PSMA-targeted imaging and therapy has become a new paradigm in how we look for prostate cancer and how we treat metastatic prostate cancer. Right. This is from an article in one of the world's most prominent medical journals called the New England Journal of Medicine. This is the article that shows that Pluvicto, which that's its marketed name, its name that I know it as is lutetium-177 PSMA 617. It does better. It keeps patients alive longer than other therapies that would be considered standard of care. So this is really the manuscript that launched the field of PSMA targeted therapy into a new era where this is now standard, and we're all looking for better ways of using this and better therapy agents to help patients with prostate cancer. So I wanted to alert the group of 2 trials that are currently ongoing, one that we've had ongoing for a while now and several patients have participated in, and one that we just opened, so I wanted people to be aware of it. The one that has been open is a trial of 225 actinium PSMA. This is for patients who have already received Pluvicto or another lutetium agent and have progressed after receiving Pluvicto. So Pluvicto uses beta radiation. This actinium agent uses alpha radiation, which is 100 times stronger than the beta. So while this Pluvicto was a first step, this is now an even stronger step for the treatment of metastatic prostate cancer. So if there are patients that have had Pluvicto before and are now unfortunately progressing again, I have an agent that's even stronger than Pluvicto that can be used as a next line of therapy. And it tends to be much better tolerated than chemotherapy. So patients like to get onto my trial because they get this radiotherapy, which has fewer side effects than the chemotherapy that they'd otherwise get. So that's been ongoing with us for a while, and we have 8 or 9 patients currently enrolled on that trial. This is the trial that just opened. So the group that makes Pluvicto is interested in knowing, should Pluvicto be used by itself or should it be used in combination with other medicines, as Neil called them, the ARPIs, or the androgen receptor modifying agents, these ARPIs. So we just opened a clinical trial for patients with metastatic prostate cancer that have been treated with one and only one ARPI. These are the 4 ARPIs that are currently in use: abiraterone, which is marketed as Zytiga; enzalutamide, which is Xtandi; darolutamide, sorry I spelled it wrong here, which is Nubeqa; and apalutamide, which is Erleada. So if you've had one of these, and usually people start with abiraterone or enzalutamide, if you've had one and only one of these, and then unfortunately there is progression, I have a clinical trial where we can get you either Pluvicto or Pluvicto plus another one of these ARPIs. So for example, if you had abiraterone and you start progressing, then you would get Pluvicto plus enzalutamide. And this is a way to receive the Pluvicto therapy, number one, on a clinical trial so that you get all the excellent attention that a clinical trial brings to you. And number two, the medicine is provided to you free of charge because it's on the clinical trial. Novartis is paying for the agent. So this is a way to get Pluvicto therapy for free instead of the cost that is normally associated with Pluvicto. So I'm here to announce this new clinical trial. Please spread this to your acquaintances, the people that you know with metastatic prostate cancer. If they start receiving an ARPI, one of these 4 medicines, if and when there's a progression, then I have a trial which can get them Pluvicto or Pluvicto plus another one of these medicines and get it to them for free. That's really the highlight of what I wanted to announce, as well as remind people that if you know anyone who's on Pluvicto or had already received Pluvicto in the past, and now they're progressing again, we have a trial of something even stronger than Pluvicto. Here's where I'm sitting right now, my office here in my home in the Molecular Imaging and Therapy Center at Hoag. This is where we do our work. In addition to the standard of cares, we now have 30 different clinical trials for prostate cancer, breast cancer, neuroendocrine tumors, pancreatic cancer, lung cancer, myeloma, and others. And my contact information is down here in case anyone wants to reach out to me for questions about what I just presented, or if they have any other questions regarding cancer that they want answered. And thank you very much for the opportunity to join your group again.
Thank you, Dr. Gary. Why don't we open this up? Let me see if I can see you all and open this up for questions.
One of the things that has come up at some of our meetings, Gary, is how low can the PSA be before you really should get a PSMA PET scan? And that seems to be a moving target depending on who you read. But our guys are very precise about their answers, so maybe you could work that into your answer.
You mean how low should it, how high should it be in order?
Yeah, how high do you have to let it go? If you're at 0.1, or should you wait till you're 0.3 or 3 or what?
It depends. There is a accepted answer for that, but then people don't always follow the accepted answer.
Yeah.
If you're post-prostatectomy with a biochemical recurrence of a PSA of 0.2 or higher, that is enough to trigger a PSMA-targeted PET scan, like a PYLARIFY PET scan. If you are post-radiation, then it is not 0.2, but rather based upon what your nadir is. What's the lowest PSA you had after radiation, because it usually doesn't dip that low. So what you're looking for is increases above your nadir to trigger a PSMA PET scan. But most people are post-prostatectomy, and then biochemical recurrence is 0.2 nanograms.
And does that depend on which agent you use?
Nope. Any of the PSMA-targeted PET agents.
Very good. That answers that.
Hi,
Backyard.
Gary.
Yep.
Quick question, kind of question suggestion, more on your new job with the Molecular Imaging Society.
Yep. Society of Nuclear Medicine and Molecular Imaging.
Okay. Dr. Metzger put out a bunch of links, one of which referenced back to that organization, talking about percent change of treatment after using the PSMA PET CT, the percentages of treatment that changed as a result of targeting with the PSMA PET CT scan.
Yep.
Now, so statistics. Now, related, and I don't know who to bring this to, but an interesting statistic to compile would be for someone who goes through that imaging but doesn't show anything, is in progression, but has elected to keep waiting to find something with the scan, and whether any statistics could be compiled on results, because the statistics seems to be for everything. But this would be a new one, and I don't know who to bring this to, who might compile something like that. What organization? Do you understand what I'm saying?
I get the question. It's a good question. For patients, it depends what percentage of patients' management is changed by the scan. We know we have some data available on that already, and it depends upon the clinical indication for which they get the scan. So if the clinical indication is biochemical recurrence, more than half of patients who get a scan it changes the way that they're managed because it is very sensitive for the detection of that biochemically recurrent disease. For patients that are getting the
Right.
scan when they're newly diagnosed, so they're considered newly diagnosed but high risk for metastases, it is about a third of patients have their management changed by getting a PSMA-targeted PET scan in that clinical indication. And then if you're getting a PSMA-targeted PET scan because you are being considered for PSMA-targeted therapy, about 10 to 15% of patients who are scanned for that indication, the scan tells them that the therapy is not what's optimal for them. And again, that's what I really love about this field. We do the imaging first, and we can tell from the imaging if the therapy has a good chance of working or not. And we know that about 15% of the patients that we scan for that clinical indication, we find out that the therapy is not what is best for the patient, and then we move them to a different type of therapy rather than the radioligand therapy. So these numbers are available. It depends upon what is the chance that the scan impacts the next step in your care, depends upon what is the clinical indication that the scan was ordered for. And those are the three most common reasons why someone orders a PSMA-targeted PET scan, and the approximate rates of management change related to those three reasons.
Okay, but now a fourth statistic, which doesn't exist yet, would be where the scan has shown nothing. In recurrence, the scan has shown nothing, and statistics on ultimately how that impacts treatment and life.
We know that if not showing up any disease on the scan is a positive prognostic indicator, right? If you don't have disease, which makes sense, the less disease you have in general, the better you do. I do not have any further statistics at this time to provide to you. There are researchers around the country, around the world, that are always looking for better statistics and better applications of research. Although I do not know anyone that is personally, I don't know anyone that is currently specifically working on if your scan is negative, what does that translate to for an individual patient in the future?
Okay.
Thank you, Bob.
All right, thank you. Thank you, Gary.
Question, please, with the more powerful agent, 100 times more powerful.
Yep.
What happens with side effects like the dry mouth? It would seem like that would soar.
That is a great question. And indeed, the dry mouth is the problem with the actinium PSMA. We know that these agents go to the salivary gland, and actinium PSMA has greater problems with dry mouth than the lutetium agents like Pluvicto. So that is one area where the actinium side effect is worse than the Pluvicto. Pleasantly enough, the other side effects actually seem to be less for the actinium PSMA than they are for the Pluvicto, which already has low side effects compared to chemotherapy. Because the agent being so much more powerful, we give a lot less of the agent, and then you end up getting less bone marrow toxicity or other toxicity. So you hit the nail right on the head. The problem with actinium PSMA is salivary gland side effects. Other than that, it looks even better than lower toxicity profile than Pluvicto. And patients it just happens to be that patients with metastatic prostate cancer, they've tried a few therapies, they've tried Pluvicto. If they're still progressing, you do have to worry about that salivary gland dysfunction. But most people are willing to deal with the salivary gland dysfunction in order to try and control their metastatic prostate cancer.
And how control? Well, how would you control it?
How do you say that again, sir?
How would you control the dry mouth that results?
Yeah, there are all sorts of people who are working on ways to deal with that dry mouth. Like some people they've tried cold packs, hot packs during and after the administrations of the agent. They've tried botulinum toxin, right, to try and reduce the uptake of the drug. Nothing seems to be great. If what I have seen, I've had patients that have that salivary dysfunction both after Pluvicto and after the actinium PSMA, and those patients need to more commonly carry water with them to keep their mouth moist, and they may need some salivary replacement agents when they're eating particularly drier foods.
Thank you.
Neil, there's one question, or Dr. Gary, there's one question from a friend of ours who is in Oregon asking if you have to be in California in order to participate in the trial.
No, you do not. You need to be able to get to a place that has the trial. So I'm very happy to have people, and we've definitely had a number of patients from out of state participating in our trials. They have to come, for people to participate in trials that I have open, they have to come to Hoag in order to participate in the trials, because we need to collect the information, the data on the trial that the trial is trying to collect. So we can't do it in your own doctor's office. It has to be done in my office. But there are, if you are in Massachusetts, then there are going to be places that have these trials open closer to you than Hoag, and we can direct you to the closest location to you for being able to enroll in the trial.
Well, thank you very much.
There was a question regarding what PSA level is required to be part of the trial, which is Pluvicto versus Pluvicto plus ARPI therapy. In order to qualify for that trial, again, you have to be post one line of ARPI, whether that's any of the four that we discussed. And then you have to have quote unquote progression, which is shown by one of three things. Number one is a PSA increase, 2 increases in PSA above a starting level of 2. Right? The second is progression on a CT scan by a criteria called RECIST. And the third is progression on a bone scan by something called Prostate Cancer Working Group 3 criteria. That's not for people to memorize or try and remember, but just giving you a rough idea that you can be, to get on that particular trial could be because your PSA is increasing. It could be because new things on a bone scan, or it could be because you see something new on a CT scan. And instead of trying to memorize what those exact criteria are, if there is someone who's been on one ARPI and thinks they may be progressing, I would be happy to receive a note from that person, or we can direct you to another site that's closer to you so that you can be appropriately screened to see if someone is eligible for the trial. You don't have to remember all the eligibility criteria. We can check.
Okay, let's go down the list. Anybody else would have a question for Dr. Gary? I have Russ. Go ahead, Russ.
Hi, everybody. Just a couple of quick questions. In some cases, I'm going to say I'm asking for a friend. And I actually am. I am a prostate cancer, but it has not metastasized into bone. But I do have a friend who it has. I'm in Colorado, which is number one. As far as the trial is concerned, is there any place in Colorado you're aware of?
I would have to look. I don't know of any place offhand in Colorado, but if we know where you are, if a colleague wants to know about that a particular trial, we can find out where the closest site is to them.
My guess is the best chance would be Anschutz in Denver.
I'm afraid I don't know offhand all the different sites that have the Pluvicto versus Pluvicto plus ARPI trial. It is actually a newer, we just opened it, and we're one of the first sites to open it. So there is likely to be more sites as time goes on, but at this point in time, I think there are only a handful of places that are currently running this trial. And I don't know all the different ones. I don't know the names of the places that are currently open offhand. But if someone is interested in that particular trial, if I get a note from them, an email from them, I can find out the closest place to them that currently has the trial open.
And Neil, what's the best way to facilitate that? If I drop my email in the chat and that could be forwarded to you, or
you can send it here. Let me put up my email again. Let me see if I can share.
And Russ, that'll be on the posted video as well.
Okay, and I can pick it up that way, Dr. Ulaner.
No problem.
So not to cause you any hassles. So the other two questions I have is what I was trying to understand, and there was a graph there for people who have extensive bone cancer. I've heard really good things about lutetium-177, but in general, I think you made a comment about it isn't a cure. It pushes things off for a time period. The part I was trying to understand what that amount of time was. It seems like it does good statistically, all that, and the charts indicate good. I didn't absorb what it really meant.
You got it. I'm going to go right back to this slide. When we look at what we call survival curves, this is Pluvicto, the percent of patients that are what we call overall survival, still alive. This is months after being put on treatment. So we can see that, of course, the longer you go, fewer patients are alive. That's just the unfortunate fact. And what we tend to see, if we look at the Pluvicto versus the standard of care at any point of survival, the survival is about 6 months different. So the Pluvicto, on average, is adding, I would say, 4 to 6 months of life to a patient with metastatic prostate cancer. But for any individual patient, they may get a substantial benefit in the realm of years, and some patients won't get any benefit whatsoever, with the average benefit probably being around 6 months.
And as opposed to, okay, that's the advantage of Pluvicto, and I get that part of the 6 months. But the total number of years on the statistical average for doing treatment as opposed to not doing any treatment, is that a couple years if I look at this, or more?
Yeah, I would call it, there are not many people with metastatic prostate cancer that choose to get no treatment whatsoever, but that's certainly a possibility. Someone says, I don't want to be treated. I'll just live my life, whatever I have. And what you tend to get is when you do get treated, you're able to get more than one treatment. You start with you start with hormonal therapies, the ARPI, you move to a radioligand therapy, maybe Pluvicto, you move to a chemotherapy. So you can get 3, 4, 5 lines of therapy before we run out of arrows in our quiver of useful agents. And to overgeneralize, but if each agent is able to add 3 to 6 months of benefit of life to a patient, then being able to receive 4 or 5 lines of therapy probably makes a difference of about 2 to 3 years in total.
And I'm asking that question because this is a person who is reluctant. And it's sometimes it's a state of mind of it's not worth it.
There are different people. who want that extend. There are some people who say, I want to live as long as physically possible. And to other people, the length of time is not as important.
Yeah.
They want to live well without having to deal with going to the hospital for therapies. And while that's a minority of people, I think it's still a respectable opinion to take. If you're not trying to live as long as possible, then you don't need to try all the medicines.
And part of my source of questions was simply, I had the impression that lutetium-177, how do you say that, was better than that. Instead of the 1 or 2 year, 6 months or 2 years extension, it was a larger extension than that. But unfortunately, I guess that's still not the case.
It is, and what we're talking about is averages in large numbers.
Yeah.
So
Understood.
on average, someone might gain 6 years of life, 6 months of life from using it. But then I've certainly seen patients who've gotten no benefit from using the agent, as well as patients who have gotten such remarkable responses that they've gained years of life. When I tend to show an example of PSMA targeted therapy, I show one of the best examples that I've had, right? So this is a patient that gained years of life from their PSMA targeted therapy, but that's not every patient. So that when we average it out between all of the patients, the average benefit is probably around a half a year.
I appreciate it. Thank you for putting that so distinctly. And appreciate the response. Thank you very much.
Thank you. I've got somebody talking in the background, not sure who it is. With that, are there any other questions? I think I had one here from Paul, who's asking, is PSMA targeted therapy effective limited by 1 or 2 hip replacements?
Is it affected by hip replacements? Nope. You can have hip replacements. The therapy will not affect the hip replacement. The hip replacement will not affect the therapy.
Excellent. I am scanning here to see if anyone has questions. I see Brian has a question.
Just a quick question, follow up on Russ's there. In the survival, is it a standard deviation or is it a normal distribution?
It is
More or less.
survival. It's not a normal distribution because what you tend to get is some patients get a remarkable response and more patients tend to group up in the earlier few months to a year. So when you look at survival curves of any individual patient, more people are here, and then you get a few that get remarkable. So it's not a standard deviation.
Standard. So there's no point in looking at standard deviation. Okay, thank you. That's all. Thank you. Okay.
Is there anybody else? If you could speak up, and I'd be glad to take your question.
I got one question.
Okay, go ahead.
Doctor, when you talk about a 6-month extension of life for these different therapies, what's the quality of life?
Depends upon the side effects that are suffered, right? So the radioligand therapies, again, tend to have rather tolerable side effects, particularly compared to chemotherapies. So the life that is gained tends to be very good months of life. Now, I don't want to downplay chemotherapy, but chemotherapy tends to run with greater side effects. So maybe the quality of life is not as good as for most people, as after radioligand therapy.
Okay, thank you.
Anything else? I thank you very much, Dr. Gary, for your time. And we look forward, as always, to having you back. And what we're going to do pretty soon is stop recording, and we'll get on with our support group meeting.
All right. Please let me know how I can be of assistance in the future.
Thank you.
All right.
Thank you very much.
Bye-bye.